So the second talk is on management of varicose bleeding, and it should be the cover slide to start with. It has some varices with my name listed underneath it. So we'll try to cover this topic. If we could go to the next slide, it has the title, Varicose Bleeding. So what I'll try to cover here in the next 20 minutes is to talk a little bit about how varices form and why they bleed, and then what to do when they bleed, including what the target hemoglobin is, antibiotics, vasoconstrictors, and endoscopy. It can be a little scary when you see the blood squirting across, as you see in this slide here to the right. And then when to consider a Minnesota or Blakemore tube, and then when to consider a TIPS. So if we could go to the next slide, which is the case. So this case is a 45-year-old alcoholic gentleman who presents with hematemesis and confusion to the ER. On exam, you're told his blood pressure is a little bit low, he's got asterixis, and he's jaundiced. You get some labs back, his white count is 5, hemoglobin 9, platelets 50. Got a high AST to ALT ratio and a high bilirubin of 10 and INR of 2. So in the ER, they start fluids and they start some antibiotics. And he gets scoped right away. The upper endoscopy shows 3 large esophageal varices with some red wales or blubbing on the varices, but he's not bleeding at the time of the endoscopy. So if we move to the next slide, the question now posed to you is, what should you do next? Most appropriate management of his bleeding is number A, transfuse him to get his hemoglobin over 10. B, go ahead and have him banded and start some octreotide. C, place a TIPS urgently. Or D, give that recombinant 7A to help clot formation that we talked about.
Okay, so why doesn't everybody vote 1, 2, 3, or 4? All right, so 92% say number 2, and a couple of people wanted to know what a WALE, what a whale is.
Yeah, so that's great. Everyone knows this one, got it right. A whale is just this little blubbing on the surface of the varix, which is more likely to bleed. So that's what a whale is, a British term. So if we could go to the next slide, varicose bleeding overview. So again, the understanding the substrate and how these form, I think, is important to know then what to do. So first off, varices are most likely to form in patients with cirrhosis. And amongst cirrhotics, anywhere from 30 to 70% will have varices. It depends on the severity of their liver disease. And we've actually done some prospective studies that if you start off with a recently diagnosed early compensated cirrhotic and you follow them with annual endoscopies, the rate of new varices formation is about 6% per year. So obviously over 10 years, and someone with cirrhosis, they could have as high as a 50 to 60% chance of developing varices. Now, not all varices bleed, but a lot of them do. Probably about a third of patients who have known varices will bleed. And the risk is proportional to the diameter of the varix, or the varicose size, which your endoscopist will call small, medium, and large. And then these red whales that I mentioned, which are these little blebs on the surface of the varix itself, which is an outpouching and particularly thin part of the wall that's more likely to rupture. So that's an endoscopic sign of patients who are higher risk to subsequently bleed. We also know that patients with Child-Sturt-Pugh score of C or more advanced liver failure are more likely to bleed. And this all goes back to Laplace's law, as you know, where the tension in the varix is directly proportional to the radius, which is the varicose size, times the pressure, which is the portal pressure. And then that's where the red whale concept comes in with the wall thickness. So the thinnest part of the wall is most likely to rupture. And so that's why those red whales are more likely to rupture than patients who don't have red whales. Now, with variceal bleeding, we know with GI bleeding in general, patients bleed and they stop and then they can rebleed and so on. Here, the likelihood of spontaneously stopping is lower. It's only about 50%, and therefore the transfusion requirement can be quite significant. In recent studies, it's been anywhere from a mean of about 4 units of blood, but some patients can really bleed massively. Now, there was I've updated these data, some nice epidemiologic data to show that we're doing much better with variceal bleeding than we have in years past. And now, in-hospital mortality is only about 5 to 10%. It used to be as high as 30 to 40% in the 80s. So we've really done quite well with managing this disease state. And the patients who are more likely to die, though, are the ones who have more severe liver disease. And they don't always die of the bleeding in 2015. They can get aspiration, progressive encephalopathy, sepsis, acute renal failure, and then die from some of these other complications, although they initially presented the bleeding. But just because we're doing better in the short term doesn't mean we're necessarily doing better in the long term, because 30 to 50% of patients who have variceal bleeding will have mortality within 1 year. The next slide is a graph that I found quite interesting. This was from an analysis of inpatient discharge data, looking at the national inpatient sample. And what you can see there on the top graph is quite remarkable, in my opinion. That's the mortality of patients with cirrhosis who have GI bleeding in the hospital. And over a relatively short time period here, from 2002 to 2010, there's quite a marked reduction in the annual rate of mortality. And they used as a comparator, interestingly, CHF, where we've slowly made some improvements with medical therapy. And then they also looked at non-cirrhotic GI bleeding, where the overall level of mortality is significantly lower. It's only about 2%, and it's slowly improved as well. But really, we've made a lot of progress here in the management of variceal bleeding in patients with cirrhosis. Next slide. So if we look at the evidence contour here of what we should be doing, we have way more data here because this is a more common clinical entity than acute liver failure. We know from meta-analyses that antibiotics improve survival and reduce infections, so that's standard of care. Endoscopy is standard of care because it reduces bleeding requirements overall and the rates of rebleeding. Vasoactive drugs, like the octreotides, also reduce bleeding. And then more so in the outpatient management after bleeding for secondary prophylaxis and even primary prophylaxis, beta blockers reduce overall bleeding rates. Now, there's two things we definitely should not be doing in these patients. Do not give sucralfate, particularly in the acute setting, which forms gel in the GI tract. And the reason is that this sort of can gum up the scope and make it more difficult to actually see when you're doing the urgent endoscopy. Recombinant 7A has been studied in a couple of clinical trials and actually did not show any survival benefit, so we do not recommend recombinant 7A in someone presenting with variceal bleeding. Proton pump inhibitors, surprisingly, have not been independently studied in this patient population, but I think because of all that we know about GI bleeding, we extrapolate and give them. And in particular, it's important to remember that in patients with liver disease who present with an upper GI bleed, 20 to 25% will not be variceal because they're more prone to peptic ulcer disease and so on. So we'd want to give PPIs as standard of care. Next slide. Again, pathophysiology. Any cause of chronic liver disease, alcohol, hep C, NASH, and so on, can cause distorted microarchitecture in the liver from formation of micro and macroscopic regenerative nodules. And as that regeneration occurs to a non-normal liver, you then can get increased resistance of blood flow from the portal circulation into the liver. The portal vein, splenic vein, SMV, IMV, they all dilate up, and that's why varices form. And then we see the varices in the GI tract most commonly in the esophagus and in the stomach because of the anatomic location being closest to the portal vein. The portal hypertension is measured by basically like a swan type of a procedure where you do a Seldinger technique. You float the catheter, though, past the heart, down into the vena cava, into the hepatic vein, and you get a free hepatic vein pressure measurement and then a wedged hepatic vein pressure measurement, which reflects the portal pressure. And it's that gradient, the wedge minus the free, which is the portal hypertensive gradient. And we all have a gradient for blood to flow, and the normal gradient is 2 to 5, 2 to 6 millimeters of mercury. But clinically significant portal hypertension is when the gradient is greater than 12. Next slide. So like our patient presenting in the case presentation with bleeding, what do you do? Well, it goes back to the fundamentals of managing bleeding in any patient. You need to get IV access right away with 2 large IVs or some sort of central access. And then here, because they're bleeding, we are going to want to address their coagulopathy early on. And if their INR is greater than 1.5, we want to give FFP and platelets if needed. And I'll show you some new data that our target hemoglobin in our heads should always be 8, not 10, based upon some recent data, because actually hypertransfusion can actually lead to worsening bleeding again. Another key part of the management is being able to scope the patient and feed the stomach and the esophagus adequately. So as I mentioned, you don't know what you're going to be encountering, so we recommend getting the IV PPI going right away. But in order to help see well in the stomach, particularly as they're coming in and being resuscitated and preparing, we like to give IV erythromycin, which can help rapidly empty the stomach of any clot or Reglan, and in addition to lavage of overt clot. So I think those are important management issues. These patients should only undergo endoscopy in a monitored setting. We generally do these in our medical intensive care unit. Sometimes we'll do them down in the ER. But you have to have a lot of hands on board because these patients may need to be intubated before, during, or after. So you have to have a team there to handle this. And in particular, many of these patients can aspirate since they usually have chronic liver disease and are prone to encephalopathy. Next slide, transfusions. This is the newer data. This was published in New England Journal a couple of years ago, 2013. This is a single center study from Barcelona, Spain, where they have a concentration of hepatologists from this large city. And what they did is their own single center randomized controlled trial over 6 years, where their hypothesis was that if you target the hemoglobin for all GI bleeders to about 8 versus 10, that the patients who get less blood products would do better. And we know this from other studies about the hazards of transfusion. So you can see here in the top box that actually the majority of these patients were not cirrhotic. They were peptic ulcer bleeds, 51% and 47%. But they had a fair number of varicose bleeders, 23% and 24%, and then Mallory-Weiss tears and all sorts of other things. And then amongst the cirrhotics, they had a pretty good distributions of child A, B, and C. And then in a subgroup of the cirrhotics, they actually did hepatic venous pressure gradient measurements, which is obviously not necessarily easy to do in the acute setting. You can see they all had significant portal hypertension, the cirrhotics with the gradient of 20, and as I told you, greater than 12 is felt to be clinically significant. Now, not surprisingly, the patients in whom they targeted the hemoglobin to be 7 to 9 got less, fewer patients were transfused, and the mean number of packed red blood cells was lower compared to the ones where they were trying to transfuse to 9 to 11. But interestingly, total colloid given to both groups was about the same. So that was their randomization and their presenting features. And then the next slide shows the survival curve of survival of the conservative approach on the top versus the liberal approach on the bottom. And you can see that the patients who had a more restrictive target of only 8 survived better than those who had a target of 10. And remember, this is lumping the data together of both variceal bleeding, peptic ulcer bleeding, Mallory-Weiss, and so on and so forth. And in the paper, they nicely described that actually the greatest benefit that they saw in the differences were in the cirrhotics with a hazard ratio of 0.3. So probably, again, this concept that if you overtransfuse a cirrhotic, they will rebleed from the barracks in the first place. So we've clearly learned, I think, from this study that it's important to not overshoot in these patients. Next slide, infections. So as I mentioned, this is a big problem, either precipitating the bleeding or happens during their ICU course. 20% will be infected right from the get-go, and then 70% will develop an infection during the hospital stay. They oftentimes get Foley catheters and lines placed. So there's lots and lots of data here that broad-spectrum antibiotics work and should be the standard of care. Reduce infections. Most importantly, you improve survival. And the greatest benefit is in the sicker patient and giving it before you do the endoscopy. So again, ideally from the ER onward, you're getting a broad-spectrum cephalosporin, levothyroxine, unison, et cetera, going in your patients. Next slide, pharmacological therapy. This, again, should be started early on. The idea here is to try to reduce splanchnic inflow that's feeding the varices. And octreotide has been around for quite a while. You give it initially as a bolus and then as a continuous drip. Pretty well-tolerated drug, particularly compared to vasopressin that we used to use years ago. And again, meta-analyses, it had a superior control of bleeding and fewer side effects, so improved efficacy, less safety concerns is a winner. And then what about just octreotide versus endoscopy alone? Well, similar rates of bleeding control, rebleeding, and mortality, but really the field quickly moved to combining octreotide with endoscopy versus endoscopy alone. And again, multiple meta-analyses here show that the combo works better and it makes sense. You're giving local therapy through the scope, and then you're giving visceral therapy through the drug. So you have better bleeding control, less rebleeding, but unfortunately did not improve survival. If for some reason you don't have access to octreotide, you can use vasopressin, but certainly beware of the peripheral vasoconstrictive effects and cardiac effects. So you need nitroglycerin. Next slide, the endoscopy. This is a picture of us actually banding a patient. This is a look through the distal part of the endoscope with the string that we're going to pull to deploy the black band over the barracks when we go to band it. So when you want to do therapeutic endoscopy, the question is whether or not you can use conscious sedation versus intubation in an unstable patient, and that's literally a case-by-case decision. My sense is if they're hypotensive, before you've even started and given any sedation, you're going to have to resuscitate them and likely need to use some form of propofol or possibly even intubation. You can achieve hemostasis in 80 to 90% of cases with urgent endoscopy, and we've moved largely to band ligation versus sclerotherapy. So the difference is band ligation I've shown you there where you're going right at the source of the varix and directly banding it and causing it to clot off. Sclerotherapy is done differently where you use a catheter and you inject the varix with a sclerosant. Again, this is somewhat old literature, but the banding, because it's more superficial, has less side effects, less strictures, less disseminated infections, and less ulcers. The only difficulty with banding, as you can see here, your visualization is reduced because of the device itself. So sometimes your endoscopist may fall back to sclerotherapy, at least to get control of the bleeding, and then may go back to do banding once things are a little bit better visualized. Next slide, early variceal rebleeding. So you've gotten control 80 to 90% of the time, but then what's going to happen during the same index hospitalization, 10 to 20% of patients will rebleed. And it's time dependent. It's most likely going to occur within the first 24, 48 hours, but it can happen 72, 96, and so on. So while in the hospital, you want to continue the ectreotide, continue the blood products, antibiotics, and most importantly, repeat the scope, because they may be bleeding from something that you didn't see before. They could be bleeding from ulcers that you created from your banding. They could be bleeding from gastric varices that were not well observed during the initial endoscopy. So you really need to know what you're treating with the repeat endoscopy. So if a patient has gastric varices, there's really not much role for endoscopic therapy, and they're likely going to need a TIPS. And if they're actively bleeding and unstable, you may need to put in a Blakemore tube to temporarily bleeding to get them down to the angio suite. Next slide is a picture of a patient with a Blakemore tube in situ. As you know, these are large diameter rubber devices that now have a radiopaque tube, which makes it easier to read a chest x-ray after you insert one. These are not easy to insert. They're much more difficult than an NG tube. My suggestion would be to have your hopefully experienced endoscopist there with you as you're inserting this, if they're not doing it already. You always need to test the tube before you put it in the patient, particularly if it's an older tube, because the latex balloon can get little cracks and things, and you don't want to learn that after you've inserted it into the patient. So we always test the gastric balloon first by inflating it outside the body and then deflating it, and you usually need to use hemostats on the tips of the ports to keep the air from insufflating. So you pass it either orally or through the nose. These patients have to be intubated. It's very uncomfortable, and it's unsafe to try to pass it in someone who's awake, because you oftentimes need to use your fingers as you're inserting it. You then, after you pass it through with lubrication, before you inflate the gastric balloon, you always need to get an x-ray to identify where it's at. So you initially just give 25 cc's into the gastric balloon so you can see it. You do your x-ray, and then once you've confirmed that the gastric balloon is in the stomach, then you can inflate it up to 250, and then that's when you pull back to create tension on the GE junction, and that will usually control bleeding in most patients. Very rarely we have to inflate the esophageal balloon, which is a separate port in a smaller volume. The reason we're real reluctant to endorse esophageal balloon inflation is you can cause ischemic necrosis much easier in the esophagus than in the stomach. So you really don't want to have to do that unless your gastric balloon is failing. These are highly effective, but now you've got an intubated, sedated, oftentimes paralyzed patient. Where are you going after you put the balloon in? You basically bought time to get them to something else definitive, which is usually going to be a TIPS in most of these cases. And again, there is some hazard with this, inserting these balloons. Next slide, a TIPS, transjugular intrahepatic portosystemic shunt. It's done through a Seldinger technique, where again you obtain access radiographically into the right hepatic vein. You then, through a series of small needles, can gain access from there into the right portal vein. You then introduce an angioplasty balloon in that cartoon C, and then you put a wire mesh stent to keep the tract open after you've established the tract in D. These are difficult procedures to do, usually in larger hospital settings, and but they work quite well for decompressing the portal circulation. Next slide. The salvage tips for refractory variceal bleeding. So we don't tend to use this primarily when the patients are coming in right away. We usually start with the endoscopy, which is usually effective, and the patient rebleeds or has gastric varices, that sort of thing. That's usually when we go to a TIPS. They work quite well, but there's certain patients you should not put them in. So if the hazards of the TIPS is going to be greater than the benefit, and that would generally be very high MELD patients, MELD scores, or very high CTP scores, those patients have a very poor ICU survival in the first place. Certainly if they have right heart failure or pulmonary hypertension, the TIPS won't work, so we don't want to do that, and we've got to get an echo in everyone before we put a TIPS in. And then if they have cancer, whether you know it or not, in their liver, or portal vein thrombosis, it may not work as well. So everyone, before they get to TIPS, always has to have a surface echocardiogram with Doppler and a liver ultrasound with Doppler to exclude those contraindications. Next slide. So how good is TIPS versus endoscopy? Again, there's meta-analyses here. And, it's more effective than endoscopy for controlling bleeding in the long run, but you also tend to get a little bit more encephalopathy because you're creating a portosystemic shunt, which is why we don't tend to do it right away in the first time bleeding. Overall survival from this meta-analysis was similar. Next slide. What about surgery versus TIPS? Because a surgical shunt is, a decompressive shunt, and this is a radiologic shunt through a TIPS. There's only one study that's ever been done on this. This was a multi-center NIH study published a couple years ago, 140 patients with child A-B cirrhosis. They followed them up for a little over 3 years, randomized them to the splenorenal shunt versus the TIPS. You can see that the efficacy rate was pretty similar. Overall rebleeding during follow-up was only 5.5% and 10.5%. Rates of encephalopathy were 50%. Remember, these patients were followed out over 3 to 4 years. Interestingly, you tend to, when you operate on patients, not surprisingly, get ascites early on. It's not because you have portal hypertension, it's because you've done the stereotomy and you tend to take a while to recover that. Overall survival, however, was not any better with surgery versus TIPS. And then the TIPS patients had a very high rate of reintervention. And part of the problem with this study was it was done when we only had the simple wire mesh stents. And we've already moved on to the standard of care of having Teflon-coated TIPS. So this study, although it's done, didn't show a benefit. It was done with the sort of inferior TIPS device. Next slide. So the current standard of care for putting a TIPS would be not to use the simple wire mesh wall stent, but to use what's called a Viator stent, where you have a wire mesh stent, and then you can see here in the photo that there's a Teflon coating, and that prevents growth of the liver tissue back through the wire mesh stent. And these have much better patency, and you don't have to reintervene. But at the time this prior study was done, they weren't available. But that has become the standard of care, but they're technically more difficult for the radiologist also to place. Next slide, prevention of rebleeding. So once the patient's been stabilized and hopefully getting ready for discharge, you then want to make sure they get follow-up endoscopy with banding. We generally do it every 2 to 3 weeks until they're obliterated, generally need 2 or 3 sessions. We definitely need to use BID PPIs. This has been shown to reduce the size and number of esophageal ulcers, very simple, effective therapy. And then there's data to support the use of beta blockers as well as endoscopy to prevent rebleeding by lowering portal pressures, and it's quite a significant effect, a reduction in rebleeding from 40% to 20% with giving non-selective beta blockers. And then, of course, we want to avoid drugs that will enhance bleeding, so no aspirin, NSAIDs, Fosamax, and so on. And again, look at this patient for their overall prognosis. So to summarize in the next slide, the algorithm is pretty simple. At the top, resuscitate with a target hemoglobin of around 8. You're going to give IV octreotide and antibiotics right away from the ER, and they're going to arrange for the endoscopy, and it's generally recommended that the endoscopy be done between 12 and 24 hours after the patient has presented. Again, we like to use erythromycin as well as vigorous NG lavage to clear the stomach before the endoscopy. 70% of patients will do fine. You stopped them, they go out to the floor, they go home, you repeat the endoscopy, and so on. However, 10 to 20% will rebleed in the hospital. You're going to need a repeat EGD at that time, and if you can treat it, they can go home and do okay. But if they rebleed and they keep bleeding or they have a gastric varic, they may need to go right to TIPS. And then some may present just with uncontrolled bleeding right from the get-go, or they have a gastric varix right from the get-go, and there you're going to need to go possibly to balloon tamponade to stabilize them, and again, an emergent TIPS. So last slide, to summarize my key points, varicose bleeding can be life-threatening, 5 to 10% in-hospital mortality rate. Patients with worsening liver function are more likely to have mortality. Target hemoglobin these days, key point here, is 8. It's not 10. And if you can do the emergency EGD within the first 12 to 24 hours, highly effective. But we shouldn't forget these other simple things that can make a big difference: antibiotics, octreotide, and then going back for repeat endoscopy as needed. And then if you're uncontrolled bleeding, again, balloon tamponade as a bridge to TIPS, and then the secondary prevention, as I mentioned.